Hey Sparkles, I'll be starting the stream now. Just give me a second. Oh my god, my voice is dying. Okay, let's do it. Let's do it. Okay. Hi Sparkles, welcome to the stream. Welcome to Nick's study stream. I'm Dr. Nick, the Dr. Bunny VTuber who can explode anything on touch. And today, we're not playing League. Fortunately or unfortunately, I don't know. But yeah, we're gonna be studying instead. I know a lot of people hate studying, but I have an exam soon and I need to get some studying done. 1 second, let me just quickly fix some things. Yep. Thank you for the check-in. Hyper, welcome to the stream. My thirst is still available to catch. Oh my god, 1 second. Why is this locked? Shit. Okay, my webcam, I'm using my phone as my webcam, and the camera stand to record it, but oh my god. It's so fucking unstable. The stand keeps falling off randomly. I just hope it doesn't fall my way, because I don't want to do a face reveal yet. I'm not gonna dox myself, guys, come on. Hope for another day, not today. Well, I'm CS major, but here to study bio. MG. Okay, more than biosurgery. Good luck with that. Well, I was trying to fix the Spotify inbox. It is not locked. Why was it not moving? Okay, there we go. Now it moves. Now I kept it all the way up button. Okay, I know you guys can't see it very clearly. Let's see if this kind of fixes it. Okay, that is making worse. Why is it so tiny? Why is it so tiny? Well, okay, there. What's wrong with this? Okay. Okay, what the fuck? My bad. Oh, it's on the keyboard. It keeps throwing the stand down. Okay. I realized it's the issue. There we go. Let me just remove the black. Bye. What the fuck? Okay, there we go. I don't. What is this? What is this Samsung crap? How do I remove it? I'm sorry. How do I remove this? Is it just gonna be there like that? How do I make this disappear? How do I make this disappear? How do I make this whatever? Let me have a better idea. It's not moving. Okay, there we go. The better idea is to anyway, there's nothing much to see on top. Much better. Okay, now the Samsung thing is gone. It was some sort of a device list thing. I don't know what the fuck that was. I don't know why it was not going, that's the thing. Okay, I know it's still blurred, but okay, here you go. Pictures. I hope you can see the pictures. Let's start from the beginning. So I'm not gonna be teaching you guys because this is a revision stream for me. I will be quickly going through and blabbering about stuff. My condenser keeps falling. Why does everything keep falling today? Is it supposed to fall like this? Yeah? Okay, there we go. No, it's too far now. Oh my god, let me just quickly. Okay. Okay, I just had to set things up because camera thing. Okay. Okay, let's do it. My hands are here. I need a pad. Let me see my collection real. Whoa. I always see why the camera keeps falling. It keeps moving the desk. I'm gonna get a pen. Hopefully it works. Okay, it's a new one. Is it new one? Hi. I don't know what to call you, bro. I'm gonna just call you bro. Lazy fanboy. Okay, first thing, I'm not a fanboy. My chat titled me as a fanboy, so I lived up to it. Second thing, yeah, I'm a div. Okay. I blame you, Sparkles, for doing this to me. Okay, I should not move the desk or the camera will fall down. Am I taxed? Yeah, that's because of my chat. Don't even a single thing hitting my brain. And what are those curses? Hernia, nihis. Oh yeah, nihis classification. It's a classification of hernia. There are 4 types of hernia. Type 1, type 2, type 3. Type 3 has again 3 types: 3A, 3B, 3C, type 4. Okay, let's not look at the book. I can't say this without looking at the book. I'm looking at the book. Okay, type 1 hernia is need PG. I'm writing my postgrad exam. So type 1 is indirect hernia with normal internal deeping one ring. Peritoneal sac is in the internal canal. It's also, you can also call it IC. Type 2 is when there's a laxity of the deeping one ring causing an indirect hernia with posterior wall intact. Type 3, type 3B, type 3C. Type 3A is direct hernia with the posterior wall defect. Type 3B is pantaloon hernia where both direct and indirect hernia exist. Type 3C is femoral hernia. Type 4 is not exactly a type, but it's a recurrent hernia. Again, it's under 4A, 4B, 4C, 4D. ABCD, direct, indirect, femoral, and then combined. So type 1, 2 is first indirect, then type 3A is direct. But type 4 is the reverse. Type 4A is direct, B is indirect. I'm having periods when I'm a boy. Is that normal? Why are you having periods? How are you having periods is the next part of the question. And do you have hemorrhoids? Why do you have a wag? Okay, you have a wag. Doesn't necessarily make you a female, but you can't call yourself a male unless there's a condition, which I don't think it's there here. Okay, that's an ops. Tomorrow is ops. Tomorrow, 2 days later is ops. But okay. Thank you for the follow, bro. Welcome to the stream. Okay, I do say okay a lot, so okay. So congenital hernia is type 1. Congenital hernia is type 1. Pantaloon is type 3B, as we already discussed. Type 3C is femoral hernia. So the IC, IDP, P for pantaloon, then R for recurrent. Triangle of doom. So there are 2 triangles: triangle of doom and triangle of pain. I drew a small diagram here, which is kind of explains how it's supposed to be, and I could not make sense of the diagram. So this is the myopectoral orifice. There's the rectus sheath on the medial, lateral is psoas. Inferior is why did I go? I didn't tell this. And superior is equal to joint tendon. Okay, inferior is inguinal ligament. Wait, no. Inguinal ligament is supposed to cross like this now. Okay, I did not draw it properly. I tried to draw it properly. Wait, where's the superior boundary? There's no superior boundary. Hi, Yubi, welcome to the stream. One day I hope you turn femboy. Oh my god. I don't want to lose more weight though. I hope that you took a wrong decision. You will be reading comments more than biology. Actually, I feel like I will be studying more because when I'm not streaming, I'll be playing League instead. So I'd rather have a study stream than end up like that's literally what happened today. I thought I'd do a study stream in the morning, but then I opened my laptop and started playing League, and then by the time I realized it was lunchtime, and yeah, I didn't study. And then after lunch, I started studying again, and then I ended up playing NT, which is a gacha game, and I deeply regret it. And then evening, after a snack break, I decided to start studying again, and then I ended up watching someone else stream. And I was complaining about not studying on a stream. I hope he didn't get pissed off. So I feel like having study streams is better than doing anything else, because my keyboard's blocked behind my camera right now, so I can't even access my keyboard. Are you level 57 HNT? I do grind it a lot. I grind it a lot. Okay. Let's think. So yeah, this is the inguinal ligament, and this is the lacunar ligament. Oh, this is the folding. This is the thing that cuts it out. Like that's a lacunar ligament. So inferior boundary is so this is the myopectoral orifice, or we call it as MPO. The inguinal ligament is this inferior boundary. Medial is the rectus sheath, and lateral is the gonadal vessels. What is the main content of myopectoral orifice? Is the femoral ring, deep inguinal and superficial inguinal ring. Now, boundaries of the triangle of doomsday, triangle of doomsday, is medially you have the. So this here you have Chattamatic where anterior spermatic vessels, ductus deferens. Okay, here's vas deferens. This is the vas deferens. So this is the medial boundary. Vas deferens is the medial boundary. Lateral is the vessels of the spermatic cord, and inferior is the peritoneum covering the psoas. My brain can't shake it. My brain can't take it. I don't know how. How is this possible? I did draw it somewhere. 1 second. I did draw it in a notebook. I don't know where's that notebook. Let me just quickly search for it. Nope. 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 Yep. Let's start the book. I can't find the book. Where's the book? Okay, I don't know where it's book. Wait, is that the book? Book. Okay. Please tell me this is the book. It is biochemical. More than that. Then like that. No, we don't want the book. Okay, I lost the book where I drew it. So fuck me. Please don't fuck me. I can't find it. Yeah, okay, I think let's picture it again. Let's imagine it. So I actually prefer to start from the triangle of pain rather than the triangle of doom. Okay, both are worse. Both are bad. Both pictures are bad. And that's why I need to use my other book. Where's my book? What's the book? Where's the book? Look. What the book? Oh, no, what are the keys? Okie dokie, found the book. Oh, yes, we decide the page. It's on because there's this pretty big book. And kind of from this right page, I think. Maybe? What happened to them? Okay, it's still playing. Let me reduce the volume real quick. Better. I hope it's better now. Okay. Oh my god, what the fuck is this? Right here. Cross. Penetrating a problem trauma. I think Hernia had its own chapter there, you know. Share request is on that will wake you up. I'm sorry, some requests are turned off because I'm streaming on YouTube and YouTube does not like getting copyright or 3 copyright strikes and I'm done for. And I don't know, I can't separate word tracks on YouTube for some reason because YouTube is being a bitch. So yeah, I can't really accept some requests at the moment. It's a bad idea to stream on YouTube for so long. I'm sorry, YouTube. I know you guys are hearing this. Please don't evict me. I need that partner. Okay, European Hernia Classification Society. I have to read this as well. Another herniaplasty should be here somewhere. Laparoscopic. Come on, triangle of pain, triangle of doom. Here it is. So yeah, this is much better. This picture is much better. Is it frozen? Okay, I know it's really not clear. I don't think I can do anything about it. Let me try to switch camera. Let's see if it makes it any better. Okay, now I lose flash. I lose flash or this, I think. Nope. Yeah, I don't want to pay. I don't want to pay to increase the quality. So it's okay. Skill issue, I guess. What do you mean? Leave me. I'm innocent. Okay. I'm just gonna dictate it. So this is the triangle of pain, and this is the triangle of doom. So in between the triangle of pain and the doom, what actually separates them is the testicular vessels. It's the fucking testicular vessels. So triangle of... Okay, never mind. Yeah, I'm right. So it's simple. Okay, it's really simple. So So this is the medial and this is lateral. So this is towards the body and this is away from the body. And now what we're looking at is triangle of pain, which is lateral to the triangle of doom. Triangle of doom is a more medial. So let's take the vast difference. Vast difference forms a more medial both boundary. And then there's the testicular vessels, and down inferior is the peritoneal reflection. So the peritoneal reflection goes up like this, forming the lateral boundary of the triangle of pain. And then there's the testicular vessels, which which share the boundaries, which forms the medial boundary for the triangle of pain. And the superiorly is the iliopubic tract. Okay. So easy. So this is the peritoneal reflection. You see, peritoneal reflection goes up like this, forming the inferior to the lateral boundary. You know the triangle of Doob is medial most compared to the triangle of pain. So the medial most boundary forms the vas deferens, the lateral boundary forms the testicular vessels, and the inferior, of course, from the peritoneal reflection. As the triangle of pain, what you have, the lateral boundary of the triangle of Doom forms the medial boundary of the triangle of pain, which is the testicular vessels, and the peritoneal reflection goes laterally. And then the top is superiorly is the iliopubic tract. Now, contents, the triangle of Doob is called the Doob because of dangerous bleeding. So there are a lot of arteries here, and they did not give it in order. Which aren't you supposed to be giving it in order? Okay, never mind. I'm not supposed to give it in order. Okay, but it's sort of in order. There's the external iliac vessels, artery vein, and then the genital branch of genital femoral nerve, which goes to your genital area to supply the sensory supply there. Then there's the triangle of pain, contents, which is the LCT, lateral LCT, which is the lateral cutaneous nerve of thigh, femoral nerve, so we have the genital branch of genital femoral nerve in the triangle of Doom. Triangle of Doom is medial. Medial is your genital, so genital branch goes medial. Lateral is your leg, so it's your thighs. So femoral branch goes laterally into the triangle of pain. So as I said, torrential bleeding, and triangle of pain, there's a lot of nerves. So if you injure the triangle of pain, you're gonna have paresthesia. You're gonna have shooting pain along the lateral aspect of the thigh because you affected the femoral branch of the genital femoral, mainly the lateral cutaneous nerve, which supplies the lateral aspect of the thigh. You're it's gonna be entrapped, and you're gonna have shooting pain. It's called myalgia parasitica. Trapezoid triangle of Doom and triangle of pain together is known as the trapezoid of disaster, and this is the most likely area to be injured during laparoscopic hernia surgery. So laparoscopic hernia surgery, you have two types, which is TAP and TAP. TAP is total extraperitoneal repair, and TAP is total transabdominal peritoneal repair. TAP peritoneal repair is intact. Transabdominal transfer, breaching the peritoneum, going through it and placing a mesh. TAP is of course more challenging because you're going superficially. I mean, it's total extraperitoneal. You're going outside the peritoneum, so it's more hard to do so. But it has better outcome. So between the anterior fascia and the posterior fascia, you put the balloon dilating trocar. Whereas in you of course you breach the peritoneum for laparoscopic TAP. I actually really want to continue reading this book, but it's gonna take forever. I'll give it a quick look when I have the time, but this is the last minute important thing I have to read, because I'm aiming for Ophthal, and Ophthal is easy to get in there, but I need to get at least 70% correct. So this is it. This is the final run. I have 20 days for the exam. More than 20 days, but let's take this one. Let's take almost 3 weeks left. Okay, so we're done with triangle of Doom and triangle of pain. Then we're done with my pectoral orifice as well, actually. Yeah, I already covered it in the first, because I already knew it. And then corona mortis. Corona mortis is an aberrant artery, which is not usually seen between the obturator and the external iliac vessels, or the inferior epigastric vessels. So it's actually aberrant obturator artery because it's an accessory obturator artery coming up. Yes, it's surgery right in the accessory. Fuck. It's surgery. It was surgery. It's in there. Okay, most common hernia in males and females. It's indirect hernia. Whereas femoral hernia is more common in females than in males, but it's still not the most common most common hernia in females. Indirect hernia is most common in females. Then we have a deep ring. Deep ring is a defect in fascia transversalis. Superficial ring, however, is a defect in the external oblique aponeurosis. Then the femoral hernia is 4 times lateral. The sacroinguinal hernia is above and lateral to the pubic tubercle. And femoral hernia is below and lateral, of course. That's a fucking mistake. No, never mind. It's correct. It's correct. It's correct. No. Shouldn't it be medial to the bishop? This should be medial to the pubic tubercle. No, lateral. The pubic to the bony structure. So we go lateral above like this and lateral below. Okay. I still think it's medial. I don't know. That's well. So most common nerve injury in surgeries respectively. Appendix surgery, of course, it's the iliohypogastric nerve. Open hernia, it's the ilioinguinal nerve, which causes weakening of the muscles, causing recurrent hernia. Lap hernia surgery, we already talked, LCNT. In mesh entrapment, iliohypogastric nerve is affected, causing hysteria in the anterior abdomen. Then some important one-liners about hernia. Swiss cheese appearance is seen in incision hernia. For incisional hernia, CCT is investigational choice. In normal hernia, clinical examination is more than enough, but if they ask for investigation of choice, you'd say ultrasound. But for incisional hernia, it's impossible to see it on ultrasound. You have to go for a CCT. Silk glove sign is seen in congenital hernia. Silk glove sign. Okay, babies are silky smooth. So silk glove sign, easy to remember. Mayo operation is done for umbilical hernia. Just imagine mayonnaise on your umbilicus. Mayo operation. Oh my god. I hated how surgeons learn food names. Oh. Mayo is a person, but it's mayonnaise. And pathologist surgeons love using food names. For example, Swiss cheese. They love using food names for their terminologies. So most common anterior repair is of course Lichtenstein. Most polypropylene mesh adhesions, which is a non-absorbable monofilament suture. Best mesh should have lightweighted big. Most postman hernia is not a true hernia. EHS classification. Now this is the European Hernia Society classification. So okay, this is very easy if you know. So we have the xiphoid, umbilicus, and the pubic. From xiphoid, you take 3 centimeters. From pubic, you take 3 centimeters. Above and below the umbilicus, you take 3 centimeters. And mark them as M1, M2, M3, M4, M5. So based on the location, you can say what's the hernia. Like if it's 3 centimeters above and 3 centimeters below, it's umbilical hernia. If it is laterally, it's a parumbilical hernia. If it is in the M2 region, it's epigastric. If it is M1, it's subxiphoid. If it's M4, infraumbilical because below the umbilicus. M5 is suprapubic because it's above the pubic bone. Now, this is one part of the EH. This is everything apart from inguinal hernia. Inguinal hernia is still part of suprapubic, infraumbilical hernia. Okay, so EHS also came up with the terminologies called. One second. Oh my god. So there is P/R, which is primary or recurrent. LMF, which is L is lateral indirect, M is medial direct, and F is femoral. LMF. 1, 2, 3 is the size of the 1, 2, 3 is the size of the defect. Example, 1 is less than 1.5, 2 is 1.5 to 3, and 3 is more than 3 centimeters. So if you want to describe, like example, a primary indirect hernia, you say PL, size of defect, imagine it's less than 1.5 centimeters, you say PL1. Same with direct. You're talking about a recurrent direct, RD. This is wrong. Okay, this is separate recurrent. So RN, not D, RN because it's medial, RN 1, 2, 3. Then same thing here, PF 1, 2, 3 or RF 1, 2, 3. Then we already explained this. Lumbar hernia is L4. So paraumbilical and lumbar hernia does not come under this. So inguinal hernia also does not come under this. So lumbar hernia, if you want to describe in this classification, you don't use M, you use L. Then there's Zenker's diverticulum. Zenker's diverticulum is nothing but there's the thoracosphagus and then there's the cricophagus. There's two thoracosphagus and one cricophagus forming a triangle in your neck called the triangle of dehiscence or the Killian's dehiscence or the Zenker's diverticulum. So this often happens in old age due to weakening of the two muscles. And there's regurgitation, there's food gonna be stuck, and that's the regurgitation of food and intermittent dysphagia because of food being stuck. There's gonna be bad breath, halitosis. Now I made a really small. Oh my god, what the fuck did I write here? Okay, Spigelian. Okay, there's different types of hernia. Spigelian hernia, which is for the rectus sheath. Rectus hernia is portion of the bowel being entrapped. Sportman hernia is not a true hernia, it's just soft tissue damage. Litterus hernia is Meckel's diverticulum. Pantaloon hernia, I already told, is both direct and indirect hernia. Amyant hernia, A for amyant, A for appendix. Maydel hernia, Maydel, and L comes with loops, so there's two loops of bowel stuck. Sliding hernia is where part of the colon or intestine slips through it. Peterson hernia occurs. Okay, Peterson hernia is sort of a diaphragmatic hernia because wait, is it a diaphragmatic? I think it's when you do a Roux en Y gastric bypass. It's the part of the gastric bowel going up into the diaphragm. No, I think it's that. Anyway, so Spigelian rectus portion of bowel, Sportman tissue damage, Litter's Meckel diverticulum, Litter's Meckel Litter Meckel. Or another way around is Michael Litters, some Litter Meckel. Pantaloon both, amyant, A for appendix, made the loop, two loops, dilute. Sliding hernia is part in stuff intestine slides into like the colon. Peterson hernia is hidden Roux en Y gastric bypass, which they do for bariatric surgery to reduce your stomach size. Now, Zenker's diverticulum investigation of choice, of course, is the barium swallow. Treatment of choice is diverticulectomy or treacle for pharyngomyotomy. Cut the muzzle or cut the diverticulum. Close the diverticulum. Dolman's procedure. Dolman's procedure is an endoscopic procedure where you use a CO2 laser to ablate the space. You can also give botulinum toxin, which constricts the cricopharyngeus. Then X-ray of. Okay, there's showing an X-ray. So you see this loop going, and this is an X-ray of a neonate. They pass the nasogastric tube, which loops over, so it's not going inside. So that means there is an obstruction. Obstruction, aka in most common in neonate, is the tetralogy of Fallot, which most common type is type C. Type C is proximal atresia. So I did a very neat diagram here. So type A, type B, type C, type D, and type E or type H, same thing. Type A. So type A is no tetralogy, no tracheoesophageal fistula. No atresia. Okay, there's only atresia, there's no fistula. So the esophagus is separated from the stomach. There's no fistula, so your esophagus is not in contact with the airways. Whereas type B, there's a proximal fistula with a distal atresia. Type C, there's a proximal atresia with a distal fistula, which is what we are seeing here. And okay, type D is both proximal and distal fistula with atresia, esophageal atresia. Type E or H, so it's gonna be a H pattern. There's gonna be fistula with no atresia. Okay, this is gonna. Okay, so H for H is gonna be a head shape, whereas Type A, there is no head shape, there is no connection, there's only an atresia. Type B is proximal fistula. So we're talking about fistula. So proximal is going to be first. Fistula first. So B, there's fistula. C, there's distal fistula. Proximal fistula and B, and distal fistula and C. D, there's both proximal and distal fistula. Okay. So fuck it. Of course, the first test we did was nasal gastric tube and X-ray, but we cannot do this for type H because it's nasogastric tube will pass in anyways. So for that, the most accurate investigation of choice would be tracheobronchoscopy. So you're gonna go to the trachea and see where is there a connection. Better than UGI endoscopy. Endoscopy, you go through the esophagus. Tracheobronchoscopy, you go to the trachea, which is easier to see than the endoscopy. Safest contrast to use in a child is iohexol. Treatment of choice if the patient is fit, aka normal birth weight, no pneumonia, normal feeds. Actually, we don't really talk about feeds. We do Cameron height operation or right posterolateral thoracotomy and repair. Right posterolateral thoracotomy and repair. So this means birth weight has to be more than 2.5 kgs and no pneumonia, which is also called the Waterstein criteria. And the operation is called Cameron height operation. Okay, so if there is low birth weight and if there's pneumonia, or you do a feeding gastrostomy and then you do a delayed repair. So you set it in a tube and you feed through that. For type A, which there's atresia but no fistula, you do Foker's operation. So what you do is you cut this, bring them close together and suture it back. Foker is like a forking the esophagus. Oh my god, surgeons are a bunch of perverts. Okay. And foodies. I wouldn't call them foodies because they ruin every food they use in terminologies. Okay, so type C, type D, type D should have excess hair because the air enters through the fistula. Type A and B are gasless abdomen because it's atretic. There is no air passing through. So how does gasless abdomen look like? It's completely white out. There's nothing here. Whereas this excess shadow often you can mistake for coffee bean sign, which is seen in sigmoid. Come on. Okay, we'll come to that anyways. We will come to that. Oh my god, there's mucus in my nasopharynx. It's trickling down and it's so fucking annoying. Well, I think it's because of the fan. Okay, so now the mic should be fine and like it's okay. Next is the esophageal web or Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome, or asymmetrical mucosal web, which is a reversible web. Even though they call it a web, it's not exactly a web. So it's just a constriction. It's basically a constriction in the esophagus. Females more common than men. The most common is post-cricoid or pericricoid. Sorry. Oh my god, why is that pericricoid? Perimenopausal or postmenopausal females. Most common location is post-cricoid, so after the cricoid, and associated with IDA, iron deficiency anemia, may cause neutropenic dysphagia. Low risk of cancer, but most common cancer in esophageal web is squamous cell carcinoma. Treatment is balloon dilatation for symptomatic and iron conduction for asymptomatic. Next, you have Schatzki's ring or esophageal ring, which is distal esophageal thickening, symmetrical mucosal thickening. No muscle involved, just mucosal. Trotsky's mucosal thickening. A G junction associated with sliding. So of course there's mucosal thickening, there's a constriction. Your stomach will have space to go up, causing a sliding hernia. Sliding hiatus hernia, which in turn causes GERD. No liquid dysphagia, only intermittent solid dysphagia. May cause steakhouse syndrome, food stuck at Trotsky's. Steakhouse syndrome is nothing but when you go to a steakhouse and eat a lot of steak, you're gonna feel so full and your food is just gonna be stuck in your esophagus. So that's literally what they call steakhouse syndrome, because you feel having a feeling of fullness for eating less. Investigation of choice, barium swallow. Treatment of choice, balloon dilation. Treat GERD for medical. If it's symptomatic, you do balloon dilation. Okay. Barium swallow, bird beak sign. Bird beak sign. It's a very uniform. It looks very uniform. If it's not uniform, it's cancer. If it's uniform like this, then it's achalasia cardia. Achalasia cardia is due to nothing but due to absence of myotonic plexus or brax plexus, which are basically inhibitory plexus. So there's no inhibition. It's got a contract, a distal. So that tone of the lower esophageal sphincter increases. You can see this thin esophagus here. It's gonna constrict, and your proximal portion is gonna dilate, making it look like a bird beak. So that is called achalasia cardia. So normal tone of lower esophageal sphincter is 20 to 25 mmHg. Now secondary achalasia is due to Chagas disease. Pseudoachalasia is due to cancer, which I already told you. It looks very irregular. It does not look uniform like how it is like here, but it's still called pseudoachalasia. It's not true achalasia because it's not uniform. Then it's more common in young age, 20 to 30, dysphagia of liquids more than solids. So this is the only, I think apart from cancer, this is the only diagnosis where dysphagia of liquids was more than solids. And again, this is increased risk of squamous cell carcinoma in the proximal dilated part, not the distal, but the proximal, because in this food issue here, there's mucosal damage causing proximal squamous cell carcinoma 20 to 25 times more higher in normal ganglia. So it's not just called a bird beak sign, it's also called the rat tail sign. So what's the gold standard investigation? Of course, you have to see the tone of the lower esophageal sphincter. It's also called as manometry. And based on that, you have the Chicago classification. Chicago classification is of 3 types: type 1, type 2, type 3. Type 1 is classical, type 2 is pan-esophageal pressurization. That means the entire esophagus is constricted, and type 3 is spastic. Treatment of choice: you do Heller's myectomy for type 1, type 2 with door fundoplasty, or also called partial. It does the partial fundoplication to prevent post-op GERD or post-op shoot up. What is that? Hernia. Yeah. Hiatus hernia, sliding hiatus hernia. So you do a Heller's myectomy with doors fundoplication, or partial to 70 degrees post-op fundoplication to prevent sliding hernia and GERD. Now there's a new treatment called POEM. POEM is nothing but perioral endoscopic myectomy. So you go through the oral route, through via endoscope, and you do it from the inside mucosal layer. So that you can only do in type 3, spastic type. Now, if the patient does not want surgery, you can give Botox, but Botox is Botox injection has a very high recurrence rate. Then for type 2, since the entire esophagus has gone into spasm, pressurized, you can do a pneumatic dilation. So send in air, boom, inflated, pneumatic dilation. Heller's myectomy for type 1, type 2, I already said, POEM for type 3. Which I'm definitely gonna screw up, I feel. Okay, so esophageal cancer, serrated rather, this is what I said. It's gonna be very serrated, it's gonna be irregular. So this is the achalasia cardia. Now towards the right side you see is what is your esophageal cancer. And this is not going to be us anymore. Singularity is obsolete now. The Chicago classification, we already said no preservation, pan esophageal preservation, and 3 distal spastic Ehlers anatomy, poem for type 3, and pneumatic dilation for type 2. Then corkscrew esophagus. Corkscrew esophagus. The safe just okay, that is also one of the X-ray findings. Barium sort X-ray findings. Okay, next. Slide. Okay, this is what we were talking about. Hiatus hernia. So there's 2 types, sliding and rolling. Sliding is more common, occurs in 90% of individuals. Sliding presents with GERD symptoms, which we already discussed. Rolling presents with more significant complications, when which surgery is often required. Ulcers, most commonly required surgery. Yeah, you do need to do surgery for rolling. Then ulcers in rolling hernia are called Cameron ulcers. Cameron ulcers. Treatment is fundoplication with Allison's repair or truvoplasty. Allison's repair. So this is the sliding type, and this is rolls out coming here. Rolling type. Then okay, we saw this. Retrocardiac F, so sliding hernia. Okay, there are actually 2 esophagus when you do a barium soda. This is called a esophageal dissection. I don't know what people call it. Dissection. It's UK, US, tomato. So this is sign of esophageal dissection. So you can't do anything about it. You have to do a myotomy, or you can just manage it conservatively. It's not really gonna affect you. Now, this is what you call a feline esophagitis. It's gonna be like multiple striae. This is a feline esophagitis, eosinophilic esophagitis. So you're gonna see trachealization in feline or esophageal, esophageal, like a trachea, but this actually has muscles, unlike the trachea. Now, foreign body obstruction. Based on the base of the coin, you can tell if it's in the esophagus or in the trachea. So in the esophagus, if you take an AP view, the coin should be circular, and in lateral view, the coin should be oval, whereas in trachea, it's the reverse. In AP view, it should be lateral, and in lateral view, it should be circular, oval, and circular. And a button battery, how do you say it's a button battery? They're going to be a double battery. It's called a double density sign or the double barrel sign, where you're going to see 2 rings like this. So that means it's a button battery, and should be more careful because it's going to cause perforation. Okay, foreign body, easy. Once we had an ER emergency surgery of a foreign body obstruction, and when we went in and removed it turned out to be a pin, a giant pin. I think it was almost the size of this cat, but way more thinner, and like it was basically a stitching pin, and it felt like a suicide because they were not really, the patient's family was clearly hiding something. They were not telling how it got in her mouth, or it went inside her airways. By the way, it went inside her airway, and we had to pull it out. Well, people, I don't think I did. Of course, if they do reveal it as some sort of suicide attempt or something like that, then yeah, we would have to file a legal case. We have to file an MLC. We have to change it. So they don't want to reveal anything, and we just kept quiet. She kept saying it's a Vertex, and how can a fucking needle, this big needle, go inside your mouth? by accident. Unless you're biting on it, why would you even bite on it? I mean, some people do bite on it, but why would you bite on it? Okay. So, respondents for activities of various what you should be careful. Immediate endoscopy and removal and observation. So immediate endoscopy removal if it's a sharp object, which I said symptomatic. Magnets, button batteries, size more than 5 centimeters. If size less than 5 centimeters, smooth asymptomatic, you can keep it in them under observation, and you have to wait for 24 hours and then look for the x-ray if it's not passed spontaneously. Now it's still in the esophagus, you can just do again an endoscope and remove it. Now Boerhaave syndrome. Boerhaave syndrome is Boerhaave sounds like something like a rupture, barotrauma. B for Boerhaave, B for barotrauma. Barotrauma of the left lower esophagus. So this is where we call the Meckler's triad. Meckler's triad is vomiting, retching, pain, and surgical emphysema. Hammond's crunch, pneumomediastinum the rupture, and all the air that enters your esophagus goes into the mediastinum or your chest wall. And there's gonna be Hammond's crunch, which is nothing but crunching or crackling due to air on when you auscultate. Or you can also call it crow walking on snow, which I have an idea of that. Then there's still at Boerhaave syndrome. Boerhaave syndrome investigation of choice is CCT, but in X-ray, what are the findings? In X-ray, you see let's see. So this is the right and left. Yeah, this is left and this is right, but here it looks like there's a right rupture. Look at this. There's a shift. There's a right rupture. So there's air leaking here. There's surgical emphysema. There's emphysema here. Neclero V sign, continuous diaphragm sign. This diaphragm flattens out, causing a continuous diaphragm. So there's a V shaped here, causing the Neclero V sign. Or spinnaker or sail sign or other. Then you have ginkgo leaf sign. What the fuck is ginkgo? I think this is the ginkgo leaf, which is for the emphysema. Then there's a pleural efficient. So again, as before, we already said safest contrast is iohexol. Most accurate to see leak is pyroxalo. But since as emphysema is much better option. Yeah, this is the Neclero V sign. And as I said, this is the spiracular sail sign. Next, we have caustic injuries. Caustic injuries we talk about is alkaline agents and acidic agents. Alkaline is more dangerous because it causes perforation or liquefaction necrosis. Acidic agents causes coagulation necrosis. So what are the phases following a corrosive injury, acute corrosive injury? Phase 1 is necrotic phase, acute necrosis, which is first 3 days. Stage 2 is subacute phase, 3 days to 2 weeks, where there's ulceration and granulation. And phase 3 is chronic phase, which there is secretion and scarring, which takes about 3 weeks to 6 months or more. So 3 days to 2 weeks, 2 weeks to 3 days to 2 weeks, and 3 weeks to 6 months or more. Then there's a Zagor's classification used for endoscopic classification of caustic injury, which is of 4 stages, and they don't want us to know. Do early endoscopy and assess the depth and grade of the injury. You have to do an early endoscopy and see the depth, because if you delay it, there's going to be a perforation in case of alkaline agents like factor necrosis, and I said it's just going to cause severe and stomach perforation. Not perforation, but Ulcers, peptic ulcers. I lost the word there. Caustic and malignant structure, and later can cause the cancer. So guys, don't fucking drink alkalis and acid. Don't go to your bathroom and drink the bathroom cleaner. It's just gonna burn through your esophagus, and then you end up you won't die, you just end up in the hospital. And I don't think you'd barely be able to eat anything after that until 6 months or more. So yeah, trying suicide by bathroom cleaner is no, bad idea. Don't even think about it. If you ever think about it, go to a psychiatrist, go for therapy. Because that's not gonna work. Same with hand cutting. People cut their hands and stuff. I'm gonna say that it doesn't work that way. You need to go really deep for a major artery, and it's impossible to do it by yourself. Now, because I'm saying it's impossible, doesn't mean you to go try it out. Don't fucking do it. So, caustic and malignant structure. Short and irregular resolved is malignant. Long and regular resolved is caustic. You can use the judgment call it for reconstruction, but there's higher risk for GERD. GERD. Stomach, CHPS, congenital hypertrophic pyloric stenosis. Male more common female, 4:1 ratio, projectile non-bilious vomiting, 2 to 8 weeks, single bubble sign, olive shaped lump in epigastrium. Investigation of choice is of course USG. So coffee bean sign, and the 2 coffee bean sign, one is, why can't I remember the other one? This one, it's CPCHPS. So you can see this is the coffee bean sign right here. And of course, investigation of choice is USG. So how to remember the thickness? Easy. Length, thickness, and width. Length is 4 square, thickness is 2 square, and width is 4 square minus 2. So length should be more than 16 centimeter, which is 4 square. Thickness should be more than 4 millimeter. Oh my god, millimeter. Centimeter is so big. Imagine it being so big. Length more than 4 square, which is 16 millimeter. Thickness more than 2 square, which is 4 millimeter. And width more than 14 mm, which is 4 square minus 2. 16 minus 2, which is 14. Now, what are the USG signs? You see target sign. You see antral nipple sign. Looks like a nipple. This looks like a fucking nipple. Then you see, yeah, this is the nipple here. Then you see cervix sign. This looks like a cervix. So this looks like a cervix, also called the coffee bean sign. But the coffee bean sign is also on X-ray. So if you do a barrier beam, you should see a mushroom-like thing. So this is the mushroom sign of the string sign. A tram track appearance, double track or tram track sign, caterpillar sign, shoulder sign, diamond sign. That's a lot of signs. 2D2S Chief Minister. 2DSCM. So you see target sign, antral nipple sign, and cervix sign. Whereas in X-ray, you see mushroom sign, double track sign, caterpillar sign, shoulder sign, diamond sign. X-ray, single bubble sign. Single bubble sign. Then what is the electrolyte abnormalities here? You see a paradoxical aciduria, you see a hypochloremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. Why am I saying paradoxical aciduria? Is because you have alkalosis, but you have aciduria. So since it's alkalosis, don't give rangolatid, it just worsens it. Resuscitation fluid for gastric outlet obstruction is always NS. In neonates, you can give half NS, N by 2 or half NS. So the ideal for deodorant is half NS plus KCl plus 5% dextrose. But do not give RL. Do not give RL. What the fuck? It increases the risk of alcohol losses. So surgery in CHPS is always a non-surgical emergency. So first you have to correct the hypochloremic, hypokalemic, metabolic alkalosis, paradoxical aciduria. Then you have to do a surgery. So once the bicarbonate is less than 30, once the urine output is more than 1 ml per kg per hour, more than 1 ml per kg per hour, and bicarbonate is less than 30. You do your surgery, which is the Ramstead surgery, Ramstead pyloramyotomy, where you cut the muscle and relieve the CHPS, the stenosis. Medical treatment is not exactly medical treatment, but you do endoscopic balloon dilation or atropine. Gastric cancer. Gastric cancer, most common site, proximal. I got my throat hurts. How should we even, huh? Jesus. Okay, we still have 2 hours. We still have 2 hours. We're just done with 1 hour. Okay, we covered 22 pages in 1 hour. Not bad. We can do this tomorrow morning as well. Tomorrow morning we can do a study stream. And yeah, I do need to do the schedule thingy while I'm still on stream. I just forget. So where am I? Oh, it's cold. I do have walnuts. Let me drink some water. Maybe it's gonna be right away. Most proximal. Most common site, proximal gastric cancer. More common than fundus and India antrum. Hi, Shoes. Welcome to stream. Thank you for subscribing for 9 months. You're still gay and bottom. No, you. No, you. Thank you for subbing for 9 months. Oh my god, it's been 9 months already. That's an entire pregnancy. Who's the child? Well, most common site, proximal gastric cancer, more common than in fundus. In India, antrum is more common. For classification, we use the Sieverts classification. In Sieverts classification, type 1 and type 2 is esophageal carcinoma, type 3 is gastric cancer. This is a hand cannon. But yeah, it's just my textbook. It's my textbook. Not exactly textbook, it's my revision notes. Okay. Radical gastrectomy. So for distal gastric cancer, we do a subtotal gastrectomy built on type 2 with 5 centimeter margin for. I'm gonna cry. I can't remember this. Proximal gastric cancer, you do a Roux-en-Y esophageal jejunostomy. So okay, easy. Proximal gastric cancer. So so this is the Sieverts classification. Type 1, type 2, type 3. Type 1 and type 2 is esophageal. Type 3 is gastric, restricted to gastric. So type 1 and type 2 is esophageal. So now we're talking this proximal, this the esophagus. There's no esophagus, there's the stomach involved. So for type 3, we do a esophageal jejunostomy. Take the esophagus, just remove the gastrectomy, remove the stomach. So that's proximal gastric cancer. So now distal gastric cancer, which is type 1 and type 2, 5 to -2 centimeters. We subtotal gastrectomy. We remove half the stomach, which is below type 2, with 5 centimeter margin. So D2 gastrectomy. D2 gastrectomy is nothing but for the lymph nodes. My hands are soft. I can't do the I suck. I suck at the spinning pen thing. Pen spinning. I need to take notes from seconds and camps. Okay, my hands are soft though. They are actually soft. I need to ready. This just proves that I'm getting fat. I need to reduce my weight. Okay. I'm chubby. Okay, D2. Gastrectomy, the number of nodes you remove is 16. Level 3 till the celiac trunk. And Japanese station 1 to 11. I just hate this book. There's so many good stuff that's being omitted. I just hate it. Okay, where will we be? Gastric cancers. Most common type of gastric cancer is colon, and in that the most common is rectal cancer, more than sigmoid, more than cecum. Easy to remember, rectum has a lot of shit to hold, so yeah, more shit, more cancer. Most common site of distant metastasis, just as the liver, adenocarcinoma, SCC, or carcinoid lymph nodes metastasis, because so many lymph nodes are stomach. Whereas gastrointestinal stromal tuber, nodal metastasis is rare, directly goes to liver because of the bile connection. Most portal vein connection. Okay. Most important prognostic indicators, esophagus, stomach. Okay, basically the nodes. Nodal involvement is a prognostic indicator. Mitotic index, size, site, depth. Node, bloodborne, muscle, just. Most important indicator for metastatic potential is the depth. Obviously, but I say obviously and write it as. I'd go and write it as node. Old bloodborne. Where is bloodborne? Ah, yeah, node bloodborne. So it goes to the node, and from there it goes to the blood mets. Pacemaker of the stomach is located along the greater curvature. Now, trichomonas. This is something all the ladies do. They eat their own hair, and that's how it comes out after you do surgery. I know it's disgusting. And that's why you don't fucking eat hair, because then you end up seeing this. That's just hair in your stomach. So that's trichomonas. Then this worst scenario is called Rapunzel syndrome. Rapunzel syndrome literally hair to your entire stomach during the manutention. Common in young female psychiatric conditions, surgical removal is the treatment. After that, yeah, we have to send them for psychiatric consultation. I only eat my hair sometimes, and I know how to curl. Yeah, buddy, hair doesn't get digested. Some hair does sometimes go through your bowel and escape, but most of the time it's stuck in your stomach. So good luck to whoever is operating your stomach in your future. Hopefully they don't, but if they do, they're gonna find this giant ball of hair shaped like your stomach. So this is the Rapunzel syndrome. You can see in the CCT there's, oh my god. Next, dumping syndrome. There's early dumping, there's late dumping. Dumping syndrome is mostly post-surgical, following a Roux-en-Y gastrectomy. So early dumping syndrome is when you eat it immediately. So within 10 to 20 minutes, you'll have osmotic diarrhea. Late dumping happens after 1 to 3 hours due to reactionary hypoglycemia. Insulin increases. So how to cure it? You have to take intermittent meals. Don't dump, just take intermittent meals every few hours, little by little. So small, yeah, this is the treatment. More frequent meals, eat smaller meals and snack throughout the day, up to 6 per day. Decrease carbohydrate and increase protein and fiber in diet. Give dry meals. Okay, try to control the diarrhea. Okay, now I think the entire thing is there's okay, just 3 pages of X-rays. I don't know. Welcome to the stream. Have you tried telling the patient to stop pooping so much? How do you do that? I wish someone told me I have IBS, bitch. I can't control it. Yeah, but yeah, how do you fucking tell the patient to stop doing that? I mean, what I usually do is I just give them, my brain just flopped. I mean, I didn't usually stop dumping. No, dumping syndrome is related to eating. So basically, you should not eat so much. You should eat up like split your meals into 6 per day if you have dumping syndrome, which is following surgery, post-surgery. But yeah, for patients who come with diarrhea, I just prescribe them medicines. I can't help, so patients with hemorrhoids, I can't tell them to stop pooping so much. I just give them medications to stop pooping and try to make them poop once a day or once or 2 days. I don't know. Just save those bleeding. Don't abuse your fissures any more than they already have. Just give something like loperamide to reduce the motility, or for like lactobacillus to improve your. Give medications to stop pooping. Yeah, excessive pooping is bad because it's fissures. Make pooping illegal. Oh my god. The people are gonna come constipated with big belly and I'm like, I can't poop and I'm having a stomachache. Imagine. Not pooping is a problem, and pooping too much is a problem as well. Not pooping. Constipation is defined as not passing stool for more than 3 days. It has various definitions, but 3 days is usually what we recommend. There's diarrhea 3 times a day, or change in the consistency of the stool. But yeah, whenever a patient comes saying they didn't poop for a day, they're like, they should come back after 3 days and tell me that. I'm not interested in listening to your stool stories. If they're normal, of course. If they don't have any pre-existing condition, otherwise I have to ask them until. Because after 3 days is fine. After 3 days, nothing is gonna happen inside. After 3 days is what you probably should be careful about, because you know sometimes it may be nothing. It's just them overworrying, and you give them medication and they go diarrhea. You give them Senna, you give them a laxative, and next thing they have severe diarrhea. I don't want that. That is a medical negligence in itself. You can't poop 2 times a day. I don't want to know your stool habits, sir. Mr. Juice, I don't want to know your stool habits. But yeah, keep it to a minimum. Try to control it. I don't know how to say patients how to try to control it. I can't help it. So sometimes if I just can't say it, I just give them medicines. But yeah, giving them stool medications to treat constipation is dangerous, because if it's nothing, they can ladder up with diarrhea. They can ladder up with osmotic. They can ladder up with hypoglycemia. I don't want to do that. I bet you go poop more often than I do. I have IBS. I already told you. I have IBS. I have irritable bowel syndrome. So I sometimes, not every day, but some days I have issues. And I take medicines, so I'm trying to control it by myself. I mean, actually, I have to visit a gastroenterologist after my exam. Okay, enough about my 2p troubles. That sounds so wrong. Okay, single bubble sign, gastric outlet. Now, obstruction CHP is double bubble sign, is duodenal obstruction. You see two bubbles. So basically, there's a block in the duodenum that is one bubble is in duodenum and one bubble is in stomach. So triple bubble sign is jejunal obstruction. So there's stomach, duodenum, jejunal bubble. Exam in 20 days. That's why I'm studying. That's why it's a study stream. Every day is a study stream from now on. Of course, I'll play League at night from tomorrow. But day is just study. Okay, where do you see double bubble? Anywhere with the duodenal obstruction. Example, duodenal atresia. Annular plaque does nothing but pancreas surrounding your duodenum, constricting it. Last band. Then last band is I forgot what's last band. My brain can't remember. It will remember sometime. Okay, perforation peritonitis. So there's perforation, there's air escaping into your peritoneum or your abdomen. There's air below right diaphragm, just above your liver. Immediate next step is resuscitation with IV fluids. After resuscitation, you can do a laparotomy and remove the air. So X-ray, pneumoperitoneum, you see a lot of air bubbles. Dome sign, this is the air dome sign, and this is the regular sign. Now, yeah, there's the regular triad. Regular triad. Oh my god, it's such a tongue twister. I have struggled with pronouncing R because I can't roll my tongue. So regular triad, Galston-Ilias. So this is a triad for Galston-Ilias. My dad told me yesterday, and for some reason I couldn't remember. Zoom in a bit. Okay, that's the issue here. The camera quality. I mean, it's not the camera quality per se, but it's the app quality, and it's bad. So irrespective of if I zoom in, I think it's bad. It's not gonna. And plus, there's a part of the page that's not gonna be seen. Zoom out. That's gonna be worse because everything's gonna get blurry after that. Nope, zoomed out too much. Zoomed out. Oh my god, my phone's burning hot. It's burning so much. Yeah, that's exactly. It's fine if you guys don't zoom out. Because I'm saying everything in the pictures are pretty much in the thing. I think that's fine. And I think it's better. It's better. It's blurry, but better. My phone is burning hot. Erect view. That's literally why you asked me to zoom out. Erect view is nothing but you're standing. You take an X-ray while standing. So there's erect view, there's supine view, there's lateral view. There's AP, there's PA, anterior, posterior, anterior. Then that's just views of X-rays, how you take it. There's transsectional view, which is not an X-ray finding. You see that in CTs and MRIs, transsexual. Then I know what you guys. I know you guys heard as transsexual. I said transactional. Transactional. Dude, it sounds so similar. I give you an erect view, don't you dare. Stone and ilium. So Galston-Ilias is perforation of the ilium or the sigmoid colon with the gallstone. So first, of course, is stone in the ileum. Then second is because it's a stone in the ileum, there's proximal dilation of the bowel loop, and then there's pneumobilia because of the perforation. Pneumobilia. So duodenal atresia, double bubble sign, congenital obstruction of the duodenum. The site of obstruction distal to the ampulla vaginal. Bile stained. Vomiting is bile stain. You see bile stain vomiting, whereas in CHPS or single bubble, you do not see bile stain vomiting. It is more common with Down syndrome and polyhydramnios. Okay, not oligo, polyhydramnios. Because there's nothing going inside, it has to come out, causing polyhydramnios, Down syndrome. X-ray, double bubble sign, treatment of choice, double diamond-shaped duodenal. So you bypass that part of duodenum, which is atresia, which is known as chemodoperation. Oh my god, the Japanese are the pioneers when it comes to gastroenterology. So if you have any sort of stomach issue, severe stomach issues, very bad, rare, undiagnosed, so Japan is the place to go. Maybe because they eat a lot of smoked fish, that they have so many of these, but they also have better diagnostic technologies and stuff. Okay. I was talking about sigmoid volvulus for the coffee beach. I couldn't remember the word volvulus. So midgut volvulus. BMFT, there's corkscrew sign. CECT, you have whirlpool sign. So a normal rotation of the bowel is 270 degrees anti-clockwise along the ligament of Treitz. So this is ligament of Treitz, your bowel rotates 270 degrees, and failure of rotation of the bowel leads to annular pancreas. It's annular pancreas. Okay, we'll come to that. In non-rotation, cecum is at left side, on right side, and on the main presentation is large band, is obstruction of second part of duodenum. In complete rotation, cecum is subhepatic, and it usually presents with midgut volvulus. So it is an obstruction in small intestine. You can see it's going to be like this, but large intestine, you can see a clear loop of bowel. My friend says he has a sigma TISM. What's the accent? Sigmatism? Astigmatism? Astigmatism? Did you mean astigmatism? Because that's in the eye. That's in the eye. Astigmatism is when you have hi Godo, welcome to the stream. So astigmatism, it's not astigmatism, it's astigmatism. So you have myopia, which is nearsighted, and hypermetropia, which is farsighted, and there's the astigmatism, which is also defected your circular lens, your curvature of the lens. So the vertical and the horizontal axis, it's physics. There's two axes based in your vision. There's the vertical axis and the horizontal axis. If they don't meet, then you have astigmatism. The light rays coming from vertical and the horizontal have to meet at one point, but due to the irregular curvature, due to a problem, the curvature of the lenses, they won't meet. So for treatment of that, you have to wear circular lenses. They have a little curvature, axial curvature. I mean, it's not one of those big curved glasses. Those are the olden days reading glasses, not that. These days you have normal glasses with a little bit of curve in them so that the light focuses on the axis. So intestinal obstruction, jejunum versus ileum. Okay, first thing you have to see where is this coming from. So it comes from the duodenum, then this is jejunum, and this is ileum. Ileum is way longer and thinner, whereas jejunum is more thicker and more dilated, basically. Why 40s food tastes good even though they are hospital food? What do you mean 40s? What do you mean 40s? But I think hospital food basically depends on which hospital you are in. If it's a really good private hospital, like once my dad was in AIG, which is the biggest gastroenterology hospital in Asia. Fortis, I don't know. Maybe it depends on the hospital. Some have really like 5-star rooms with a microwave and a fridge inside the room. And their food's like 5-star, really good. Whereas some hospitals have really bad bland food. Food is supposed to be bland, but also depends on how we make it. Even the 5-star hospitals have bad bland food, but they make it much better. They hold on to the blandness by making it, better in other ways. I don't know much about food. I'm not a chef, but yeah. The cheaper hospitals, the chefs are not really paid much. They're mostly like helpers type, or not with permanent jobs, or they don't really care about cooking. Okay, it's Ogilvy. No, it's not Ogilvy. I thought it was Ogilvy. Whatever. So Ogilvy. I don't think it's spelled Ogilvy. It's Ogilvy. It's Ogilvy. I remember the professor saying Ogilvy. Something like olive. I'm just gonna call it olive. What I have seen private in hospital better food. Yeah. Good private hospitals always have good food. Yeah, AIG just has the best food I've ever seen. Even the cafeteria has amazing food. They have really good coffee as well, and then they have this separate doctor's cafeteria, which is, oh my god, it looks like a proper cafe. Really good cafe. I thought I got a boy who I can cook. I can cook, but I can't cook on a daily basis. I can't cook patients' food. I can cook some good weekend meals. I can cook chicken. I can cook noodles. I can cook pasta. I can bake pizza. It's been a while since I baked pizza. And I can make tandooris. I can make good starters, but that's not something you can eat daily basis. I can make sandwiches for a daily basis, and if you want to live on sandwiches, sure. And salads, probably. Or air-fried chicken, I don't know. I did tell my mom I'd be cooking every day after my exam's done, because I want to make my own diet. And for those who just joined in YouTube and Twitch, hello, hi, welcome to my stream. I'm Dr. Nick, the Dr. Bunny VTuber who can explore anything on touch. And thank you so much, arigato, for joining my stream. Today we are doing a study stream on general surgery. Okay, very weak. Colonic pseudo-obstruction, parasympathetic suppression, and sympathetic stimulation. So it's fine. I will be streaming every day from now on. Almost like 12 hours of study stream, because that's my focus. I want to stream for 12 hours every day, at least. Hopefully. Maybe. I hope we can do this. Parasympathetic suppression and sympathetic stimulation. So this is the same distal dilation, proximal distal constriction, proximal dilation, same as what we see in the mesenteric plexus. But here we are not having any. That was my plexus. Here we are not really having any problem with the mesenteric plexus, but it's what we are talking about, the parasympathetic suppression and the sympathetic stimulation. So yeah, X-ray, you see dilated colon, cecum, excessive dilation, and gangrene, of course. We go for gangrene. Also, can you explain if thumb has 2 or 3 joints? So you can see my thumb, right? So sorry, this is cut here. Okay, so this is your metacarpophalangeal joint 1, and this is your 2. So there's 2 joints. There's one joint, there's one proximal joint which opponents. So what the muscle that makes you do this is your opponent's pollicis, longus and brevis. So this is one joint. You can see this fold. So this is one joint, and this is your second joint. So there are 2 joints. No, that's 2 joints. It doesn't have 3 joints. It has 2 joints. Whereas the rest of your fingers has 3 joints. I think you guys need more convincing than your friends here. It always had 2 joints. This is not your this is what you're seeing is your metatarsocarpal joint. This is not your thumb joint. This is your thumb joint. This is unrelated. This is your metatarso. This is not really connected to your thumb. This is what's connected to your thumb. You forgot the joint near the wrist. This is not part of. This is your entire wrist. Yeah, that's what I'm saying. I'm moving this. This is what I'm talking about. So you see this. This is not part of your thumb. This is common with all your fingers. They just don't see. It's connected with all your fingers. So I'll tell you. So this is basically concept of the bones, which most people don't get. These are your carpals. Carpals have like 8 small bones connected to your 5 metacarpals. So they like 5 long sticks, and then they're connected to your phalanges, which are your fingers. So now we're talking about your thumb. Thumb is a finger. It's a phalanx, not a phal. Oh my god. Phalanx. Sounds inappropriate in a way, but okay. So this is what you're seeing is the movement of your metacarpal joint, which is not exactly a thumb. This is your thumb. This is your metacarpophalangeal joint. So what you're talking about thumb is your phalanx. Can someone please me talking phalanx is to be clipped? Oh no. So yeah. So when we're strictly talking about fingers, we don't count the metacarpal joints. We talk about the metacarpophalangeal joints. So thumb has 2, whereas the rest of your fingers have 3 each. But if we talk about your metatarsal as well, then there's 4. Larry marathon. So you guys were wrong, and your friends are actually correct. Congratulations. Okay, drug of choice for organized syndrome is neostigmine. Neostigmine is cholinergic, which is also not that is physostigmine. Physostigmine is for atropine poison. I took so long to explain it that you can't take it one clip. Try pentatonic satyr if you can find it. I don't know, I stopped bothering about pens. I have a lot of pens. That still sounds so wrong, but yeah, I do have a lot of writable pens. That again sounds so wrong in my head, but whatever. Yeah, I'll see if I ever go to the stationery shop, which I go like once a year. I bought a lot of these and some other basic pens because I don't really have much needs with it. I don't write much. I just underline stuff. And they're usually a distraction. The better the pen, the more distractive it is. That just sounds so dirty in my head. Oh my god, can someone just fucking do a lobotomy on my head or something? Okay, microcolon. I can't take this anymore. My head has been poisoned. My head has been poisoned. Thank you, juice. And I will try it. Okay. When I go to the shop, I will. Also, we need to buy a real camera. I do have a real camera. I do have an old video camera which nobody uses anymore. It has a battery too if it's too often. Yeah, actually, I have this option in my phone where I can set the battery settings for an app in such a way that the charging bypasses the battery. So when I'm using the app, that specific app, the charging bypasses the battery, so the phone doesn't get heated. But I'm not using that right now because this is not a game that I usually use for games, but I need to do something about it. I'll look at it tomorrow. Microcolor. I hate YouTube. My which phone? S24 Ultra. The god of fucking heating. Samsung phones heat so much, I swear. My last Samsung phone, the cover came out because it bulged due to the heat. Like completely. Luckily, the Samsung, my S24 Ultra has a titanium back with a glass panel, which I cracked. So I don't think there's gonna be any bulge. I show you a microcolon as you. Fuck you. So microcolon is when your colon is too small. It just like juices thingy. I don't want to make it too uncomfortable for you guys. Hi Plata, welcome to the stream. I'm good. How are you? I'm studying right now. I'm chilling and trying to unsee what I just saw Juice typing. Drew got triple. Can't take this seriously anymore. I hate surgery. Okay, microcolons in mecolium ileus, which is most important. Next is antenatal obstruction of the small bowel. Any obstruction, total colonic aganglia. So there's no ganglion, there's no parasympathetic effect. So there's going to be full constriction, causing microcolon. So if there's basically no air doesn't pass, there's an obstruction, there's not going to be air in the colon, causing, example, meconium ileus, example, antenatal obstruction of the small bowel. So there's no air going to the colon, so the colon is going to be compressed. Usually your entire digestive system is compressed when you're an infant, and then once you breathe in air after coming out, air is going to go in and inflate all your stomach and intestines. Mine is currently unused, actually. I know what you mean, but and that is your anal canal and rectum. This is we're talking about the colon. If you have gone through the colon, you have a problem, mister. Okay. Total colonic aganglionis. Okay, so Duhl-Wilson syndrome. We saw Plummer-Wilson syndrome. Plummer-Wilson syndrome we saw in Brown-Kelly Plummer-Wilson. We saw all the way back. And now this is... Wait, where is colon? Colon is before your rectum. So basically they have your stomach, then your small intestine, which consists of the duodenum. Where is the picture? There has to be at least one picture of it somewhere. I'll save my chat. Yeah, I don't think there's a normal picture. There's no normal picture. Okay, here it is. Okay, this is a non-rotation. It's not normal. Okay, there we go. Here. Can you guys see this? So we have stomach. Okay, even this is not a normal picture, but let's ignore the ischemia part here. I thought colon is your butthole. No, it's not your butthole. So this is stomach, there's a small intestine, which is duodenum, jejunum, ileum. Then ileum goes all the way like this. It connects to your colon, which is your cecum, and connected to your appendix here. So appendix is the base of cecum. This is the cecum. Then this is your colon, which goes like a garland. Ascending colon, transverse colon, descending colon, and descending colon, the sigmoid, after descending colon, there's a sigmoid colon, which takes a turn, and then is your rectum and your anal canal. So you cannot technically go into your colon unless you pass a wire or a colonoscope, because it has to turn here like this. Wait, we literally went back searching for pictures, and then we come back to the same page we were in, only to find the picture right in front of us. Nice. Okay, now, and we're actually going to that topic. We're actually going to that point. So, ischemic colitis or thumbprinting sign? There's gonna be a faker sign. Ischemic colitis, you can see the ischemia. So this is thumbprint. I don't know how that looks like at time, but it looks more like an apple core sign, which is carcinoma colon. Okay, that's gonna be really confusing in the exam, I swear. Accordion sign, cedar membrane accordion, guys, ouch. And this is why I shouldn't put my pen in my mouth. Ends up falling on the floor and I cannot put my pen in my mouth anymore. Okay. Accordion sign or cedar membranous colitis. If there was a picture of a CT with like an accordion. What the fuck's an accordion? Sigmoid colon. Sigmoid colon. I said sigmoid colon juice. Get your mind out of the gutter, please. Okay, CT targets acute mesenteric ischemia. Emboli, more common in artery, more common in venous. Okay. Comb sign. Comb sign is in Crohn's disease. You're gonna see like patchy. It's not gonna be uniform like how we see it ulcerative colitis. You're gonna see France like striped. Sandwich or hamburger sand. This does look like a sandwich, guys. Fucking how does this look like a sandwich? It looks like mushroom clouds. Jesus. Okay, it does look like steak. It does look like a pile of steak. So I can agree with hamburger, because hamburger in Japan, but most of this crap is in Japan, they call it a hamburger steak, but that's not a sandwich. Also, it's the midnight. Are you supposed to go to bed soon? I'm not going to bed in another hour or 1.5 hours. So we still have quite a few pages we can finish. I think I can finish the entire GIT before we sleep, and tomorrow we can finish general surgery, uro, and cardiothoracic. Yeah, tomorrow by morning we should be done with surgery, and afternoon we can go to obsgyn. Okay, sandwich hamburger side, mesenteric lymphoma, diaphragmatic hernia. Diaphragmatic hernia we already discussed before, but not in detail. So we have Bordalic and Morgagni. Morgagni is nothing but anterior, right anterior, and Bordalic is left posterior. Bordalic is more common in birth. Morgagni is more common in adults. Presence of they're gonna have a flat abdomen, respiratory distress, hard push to one side, depending on the side of the hernia. So I just happened to join the butt section. Yep. Not exactly the butt section. So I don't think we're discussing about fissures or hemorrhoids in this part. That's gonna be in general surgery. This is the GI section, the major section of surgery. So cause of death, of course, is gonna be pulmonary hypertension, pulmonary hypertension, because now your gut is in your chest. Treatment, repaired through abdomen, repair done late. So you don't go, early surgery is not done. You have to first assess, resuscitate, and then surgery. Ventilation is done by ECMO, not by ambu bag. Very important. No pressure ventilation, because that's going to cause rupture, and that's going to cause it's going to escalate the respiratory distress. So no ambu bag ventilation, you do ECMO. Treatment is through abdomen, not through the endoscopy, because yeah, you're going to rupture again. and it's gonna be block constriction. You don't want to go into the whatever the fuck is going on there. You have to go from the normal side. Treatment, size of defect and time of surgery does not affect prognosis. Apple core seen in cancer very many investigation of choice. Apple peel appearance is seen in type 3 B bowel atresia. B for bowel atresia. Okay, type 3B Christmas. How is that a Christmas tree? How is this a Christmas tree, sir? What the fuck? Whoever called this a Christmas tree, I don't think he ever liked Christmas, or he's not a Christian. He just hates being a Christian. Maybe he was. Yeah, I'm not gonna comment your religion now, but I think he probably hated Christianity. The normal side. The normal side is general surgery. Okay. Intussusception. Intussusception is when one intestine goes into the other intussuscipient into. Shut up, Matthew. What happened to the music? Oh, it's loading. Okay, that something is wrong with that song. Okay. It was just Spotify being Spotify. Okay. Claw sign. You see a claw sign. So that's the intercession. So this. Can I suggest some music? It has to be NCS because I'm streaming on YouTube as well. And hello YouTube. I see more people joining the stream. So yeah, I cannot talk rude about YouTube anymore. People are there. People are there. So no, you have to play non-copyright. You have to play NCS. Maybe some other time when I do not stream on YouTube, but I really want that partner. So it's a sacrifice I'm willing to make. Okay, where were we? Claw sign intussusception, peak incidence 6 months to 1 year during your weaning phase. Frequently occurs due to okay, this is, I'm not being an anti-vax, but taking rotavirus vaccine has a rare chance of causing intussusception in the future. That's one fucking point anti-vax love to use to be an anti-vax. I swear. That's the only fucking point. Frequently occurs in adenovirus type 3 lymphoid hyperplasia that acts as a lead point of Peyer's patch. Rotavirus, okay. USG target sign, pseudo kidney sign. Variant claw sign, coil spring sign. So most common type of intussusception is ileocolic, and most common in adults is colocolic. In children is ileocolic. So ileum is smaller than colon. Children are smaller than adults. So ileocolic is more common in children, and colon is bigger. So colocolic is more common in adults. Clinical features: red currant jelly stew, sausage shaped or banana shaped lump, and empty red iliac fossa. Sign of dance? Sign of dance? Colicky abdominal pain, yep. Red currant jelly stool, sausage shaped or banana shaped lump. They're not talking about stool, they're talking about the lump in your abdomen. Empty red iliac fossa. Banana! I love the minions. I can't say that. I can't say how Bob saved it, but it's kind of funny. Speak more clearly. You speak too quick. Because I'm trying to be quick. Treatment. Reduction with air or contrast enema. Surgical reduction. Peritonitis. Shock or failed reduction requires surgery. Gangrene starts from the apex. So first treatment of choice is reduction with air or contrast enema. Okay, now it makes more sense. Coil splint. It looks like a coil. Okay. So Micro's diverticulum. I love this. I just love this. I love this part of. I don't love the disease, but I love the theory behind this, because it's one of the only things I remember very clearly from embryology, and I didn't have to remember it, read it even once, because it just comes to my mind every time I think about it. Like, I read it only once during first year, which was like 6 years ago, and I still remember it really clearly. So it's easy. So we have the vitellointestinal divergent intestinal umbilicus. Now, not the umbilicus per se, yeah, umbilicus, okay, fine. So the vitellointestinal duct usually it disappears, but in this case we have a patent vitellointestinal duct. So this is called the Meckel's reticulum. So now if the distal part is not there, it vanishes, but the proximal part is still there. Now that is Meckel's diverticulum. Now if the distal part is there but the proximal is not there, it's called the cherry red tumor or the raspberry tumor. I just remember it because of the raspberry tumor and it's raspberries. I love berries, and I hate to say it, I hate that they use raspberry here, but it's easier to remember. I just can't eat raspberries anymore because of it. So now if the vitelline duct remains patent, then from your intestine there's gonna be feces coming to your umbilicus. So there's gonna be feces from your intestine to your umbilicus. So you'll be nasal fecal discharge, pustules from your umbilicus. Okay. At the anti-mesenteric border of the ileum, rule of 2, 2% incidence, 2 inches long, 2 feet proximal to the ileocecal valve. So 2 feet proximal to the ileocecal valve, 2 inches long, and 2% incidence. It has its own, you know what? What? It has its own blood supply independent of the ileum called the vitelline artery, which also is supposed to disappear. Ectopic tissue is commonly found in diverticulum, gastric more common, and pancreatic. Okay. Now, what is the more common president? First is stool, second is bleeding. In children, bleeding is more common. Adults, obstruction is more common. I'm gonna go in the bathtub and then? What do you mean and then? What happens and then? The best investigation is technetium 99 peritechnate. And mods, I'm not, just fucking ban that. Pathetic workstation physics. The fuck? Here. Arigato. Okay. Contrast studies is best in adults for Meckel's without ectopic. Meckel's without ectopic tissue should be treated by diverticulectomy, and ectopic tissue should be treated by R&A, resection and anastomosis. I actually saw Meckel's diverticulum surgery in my hospital during internship. I went for anesthesiology. I was staying there for 45 minutes, more than 45 minutes. Just don't pass out. You're gonna drown. That's all that actually said. Did I tell you that before? How many times are you gonna ban him? Leave him alone. So buggy. Okay, that's just Twitch mobile being Twitch, I guess. Twitch mobile being Twitch mobile. Okay. Very verby. Yeah, there was that Meckel's diverticulum case I saw, but I was not talking about that, was I? Oh yeah, I was talking about the actress in the bathtub. I forgot her name. I don't know how could I forget her name. So she was in Dubai. She's an Indian actress who went to a party in Dubai, and she was drunk and passed down in her bathtub and drowned. Yep, you said you would come beat me up if I stay here more than 45 minutes. Oh my god. I don't mind. Actually, I really don't mind if you stay more than 45 minutes, but make sure you're not drunk. because that's a problem. Don't be drunk, and make sure to hydrate properly after you get out of the bathtub, or hydrate properly when you're still in the bathtub, because that causes dehydration. You're gonna feel dizzy afterwards. So here is us talking about this. Coffee bean sign and sigmoid volvulus. Virile sign also seen in sigmoid volvulus. Bird beak sign is also seen in. This is literally the same as CHPS. Okay, this is like a mix of eclampsia cardia and CHPS, but in your sigmoid column. Me finding my wet guy is you. Don't do it. I feel like you don't really feel like drinking when in the bathtub. I don't know. It just doesn't feel right. Maybe some wine, champagne if you're rich. But vodka in bathtub, huh? I don't know, I just don't feel like even drinking water in the bathtub because everything feels so soapy. Okay, bird beak sign sequel, volvulus, sigmoid. I'm so scared about my phone right now. Oh my god, it's hot. I just hope it doesn't explode. We still have an hour to go. Hartmann's procedures. Okay, this is for sigmoid. Did you use Hartmann's procedure for a ganglionic megacolon? You do, also for sigmoid. Okay. Diverticulosis, sawtooth appearance. We saw one more sawtooth appearance and the esophagus. And the jejunum. This saw our sawtooth appearances. Okay. Common in old age, West more than India. High fiber is protective. High fiber is protective, and I somehow missed that. High fiber is protective. My freaking on blade, one blade broke. What's one blade? Anyways, I'm going up there now. Okay. Oh, one blade is the shaver thing. I don't know. Yeah, you can use it for anything. Yeah, the shaver. Yeah, I heard about it. You can use for shaving your legs here, wherever you want. It's one multi-purpose thing, right? I think mine is a one blade. I just never use it for other purposes. Especially not shaving my legs. I barely have hair on my legs. Look at the chat. I basically barely have hair on my hands either. It's just not so hairy, like how a guy's supposed to be. Maybe if I lose some weight, maybe I become more hairy. I don't think it works that way. Diverticulosis presents with bleeding and diverticulosis presents with abscess. Diverticulosis prevents with bleeding, while diverticulitis presents with abscess. Itis, inflammation, infection, abscess. Osis, bleeding. Most common vessel to bleed in diverticulosis is branches of the superior mesenteric artery in the right colon. Kincaid's classification is for diverticulitis. Okay, diverticulitis. Kincaid's classification. So we're itis, abscess. We're talking about abscess. 1A, pericolonic phlegmon inflammation, no fluid collection. 1B, pericolonic abscess less than 4 centimeters. 2 is more than 4 centimeters. 3 is purulent peritonitis. 4 is feculent. So okay, this looks easy to sounds easy to remember, but it's gonna be really hard to remember because it's all over the place. So 1A is pericolonic phlegmon and phlegm. So phlegm, pericolonic phlegmon, and inflammation, no fluid collection. 1B is abscess less than 4 centimeters. 2 is more than 4 centimeters, or pelvic or interloop abscess. 3 is purulent and 4 is feculent. Okay, we're almost done with GI, and I think we can safely say we can move on to general surgery as well. I mean, there's still what the fuck? Okay, these are surgeries should be done fast. It's not gonna take a long time. It's gonna take a long time. Perforation closure, duodenal perf, grams, omental patch, ileal perforation, primary closure. Okay. I already know most of this. Dolman's procedure, endospine stapling, diverticulotomy, that was that. Verticlam focal. We already discussed all of this. Hilarious. Female operation for duodenal, labs operation for CHPS, labs band, Bishop Coop, what the fuck is it? Meconium, yes, cystic fibrosis. Bishop Coop. Okay. With this bascom cleft lip operation done for pilonidal sinus, young, 15 to 30 years, hairy, multiple opening in lower back with hair, perineals. So then we have Caridakis operation and Limburg operation done for pilonidal sinus, Bianchi's operation on lilt, longitudinal intestinal lengthening and tailoring for short bowel syndrome of length less than 400 cm. Okay. Step. Serial transverse angioplasty for short bowel syndrome. Rectal prolapse surgery. For rectal prolapse, we do Thierschweiring. Rectal prolapse, we do Thierschweiring. So we do a perineal approach. Okay, choose when to shower. He's gonna miss this. Yay! For recurrent partial prolapse or complete prolapse, only for patient not fit for surgery. Thiersch. Then we have rectal prolapse surgery or Delform operation, where we do a perineal approach for complete prolapse. Rectal prolapse surgery, Altimere operation, perineal rectosigmoidectomy. Then we have rectal prolapse surgery, Ripstein and Wells. That's a lot of rectal prolapse. Actually, they're not even gonna ask about this. Maybe they'll ask one or two. Rectal prolapse surgery, Dude operation, laparoscopic. So this is laparoscopic mesh rectopexy. Abdominal ectopexy is Ripstein and ripping. You're doing it through an abdomen. You're doing it through the abdomen. You're ripping apart Ripstein. Whereas Dur is laparoscopic. Dur is in Hindi is far. So you're going through far. You're approaching for far. You're using a laparoscope. Altinir and Delmore is. I can remember Altimir is adult, which is Jews. Approaching through the rectum, perineal approach. Fistula in Anna, due to rupture of perineal abscess, perineal opening with minimal discharge of pus, divided low and high type by anorectal ring, low type treated by fistulotomy, high type treated by ceton. Rectal cancer, anterior dissection done with cancer is more than 5 centimeters above the anal verge. More than 3 centimeters from the dentate line. Resection and anastomosis is done lower. Okay, here's my plan. I'm gonna read through all the 19 subjects the next 1 week, and after that, we're only gonna do MCQs. No more reading, only question banks. Probably do each around 500 per day. I don't know. We can do about 5,000 by the time I'm done. Chat, I'll be back in a minute. I need to go wash real quick. BRB. It's number 2, so it's gonna take 5 to 10 minutes. Wait, no, it's not number 2. I was dropping back. It's 2 minutes. Ooh, walnuts. Imported walnuts. Got these from Dubai. It's not really eat it, so just took it so that I can have it as a midnight snack. More healthy. More healthy. Okay, look, I'm back. Actually, they're so good. It's real, but good. They don't have the better taste that walnuts usually have. Really good. They're freshly. I don't think I should get the pressure. Probably make some people uncomfortable as well. These observe perianal abscess, perianal opening with minimal discharge of pus. High type, low type treated by fasciculotomy, high type by seated. I know some people are already saying I'm so sorry for this. Yeah, better play something. Okay. What's going on my server? Yeah. It is two type cattle brush and buttocks. Cattle brush is ascending and buttocks is descending. That's all I have to know. White fine, okay. Sugar baker operation. A patient in match, cytoretic surgeon have recovered. Oh. Okay, but I should stop munching on the before feel very thirsty. Night regimen used for stomach cancer of anal canal. Oh, okay, I'm not trying to be racist. It's a regimen. Of the chemotherapy and concurrent radiotherapy. Chemotherapy consists of 5-FU, fluorouracil with mitomycin or porphyramycin or cisplatin. Guys, leave me alone. I'm not. It's just that's a regimen. I didn't design it. It's the surgeons. Blame the surgeons for being racist. I'm innocent. Nonetheless, talking about the anal canal. Hereditary syndromes, FAP, familial adenomatous polyposis, chromosome 5q gene APC, AAD, autosomal dominant adenomatous polyp, and secondary 5q chromosome APC gene autosomal dominant adenomatous polyp for the 50K. I'm actually really good at surgery. No, I screwed up when it comes to NCQs, but concept-wise, I'm really good. Variant of FAP, element is called the Gardner syndrome, intestinal polyposis, lipoma, desmoid tumor, osteomas, and epidermoid cyst. Turcotte syndrome, colonic polyp with brain cancers, medulloblastoma, FAP variant, and GB and HPNCC variant. Okay, now we have got two syndromes. One is the Gardner, and one is Turcotte. Gardner syndrome, intestinal polyposis with lipomas, desmoid tumors, osteomas, and polyposis with lipomas, desmoid tumors, which are intra-abdominal, osteomas of the jaw, and epidermoid cyst. Turcotte syndrome is colonic polyp with brain ulcers, medulloblastoma, and tumor. So we need to weigh turcotte. Turban is where you are your head. So head, brain cancer, medulloblastoma. Gardner. Okay, everything else is Gardner. If there's no brain, it's Gardner. Why does that sound so wrong? I can't help it. If there's a Turcotte, turban, brain. If the brain is not mentioned, then it's Gardner's. Hematomatous polyp, PJS, Prejeger syndrome, and autosomal dominant. Most of the syndromes are autosomal dominant. Was a 19 gene STK11, SKT1. And this is what I say, SKT1, SKT11. There was that one more, SKB. No, that's 19. Okay. Not to confuse myself, LKB1. Lip pigmentation with polyps, arborizing pattern of fibrovascular cord, GIT cancer, brain cancer, lung cancer, testis or ovary tumors, Sertoli cell or sex cord tumor. Cowden syndrome, autosomal dominant, chromosome 10, P10 gene, multiple autonomous polyp, juvenile polyposis. Smooth muscle hyperplasia with an elongated arborizing pattern of the polyp formation towards the epithelial layer. Christmas tree pattern at low power. Epithelial misplacement at 10%. Huge checkers, lip pigmentation, oral hypermelanosis. I told you we can finish it really quickly. This segment has been just 20 minutes and we're done with almost 25 pages of this. Okay, just as important, just interstitial cell of Kajal, GI pacemaker, most common site in stomach, more than earlier, most positive are dog 1, CD34, and CD117 is more than 90%, CD34 is more than 70%. Most common presentation is hematemesis, has tendency for blood-borne secondaries, liver, and direct invasion. Nodes are negative. Most are c-KIT positive, while some are PTG alpha, has good prognosis. PTGF alpha has good prognosis, where c-KIT positive has bad prognosis. Two types, spindle cells 70% more common, epithelial 3%, rarely pleomorphic. Malignant potential is decided by Fletcher's criteria. Size more than 5 centimeters, mitotic index more than 50.10 hypertrophy. Metastasis vascular peritoneum. Investigation of choice is CT scan, for recurrence PET scan, for biopsy use of endoscopic use of EUS guided biopsy, endoscopic use of guided biopsy. Treatment of just surgical resection, imatinib mesylate, imatinib surgery type 3 tyrosine kinase kit, 400 mg per day, best adjuvant, using c-KIT positive, just sunitinib. Okay, so you first give imatinib. If it is imatinib, you give sunitinib. Then mitotic index side tumor size is predominant factor, whereas before we said tumor depth is more important, but in case of GIST, mitotic index and tumor size is more important. Wild type GIST cannot give imatinib, c-KIT negative. Okay. Consumptive hypothyroidism is found in GIST due to inactivating enzyme type 3 iron thyroid deiodinase D3 activity. Hematemesis. Okay, that's it. Yeah, I pretty much know all this. Mallory V stare. So if I'm just saying the heading, I know what's under the content. It's just flowing in my head at a really quick pace. So Mallory V's tear is at the G junction on the right side because the D was by which holding alcohol pinches and if gastric artery release spontaneously watermelon stomach. Watermelon stomach gave gastric antral vascular ataxia, all female genetic condition associated with chronic liver disease, chronic liver disease, chronic renal disease, and collagen vascular disease. Long-term torsions vessels in antral, often non-bleeding, conservative, more than antrectomy. Deal of elation, developmental AV malformation, because of 6 centimeters, blah, blah, blah. Okay, names of adult care, Borman's classification, important, gastric cancer, Leiden splashes, type 4. So type 1 is polyp, type 2 is ulcerative, type 3 is infiltrative ulcerative, type 4 is diffuse infiltrative, which is Leonitis plastica, type 5 can't be identified. Now we have, first is Borman classification, we just said that there's a Japanese classification, so there are 3 types, but type 2 has 3 types again. Type 1 is polypoid, type 2 is superficial elevated, type 2B is superficial flat, type 2C is superficial depressed, type 3 is excavated. This is pretty easy. Margin status for various cancer, 2, 5, 10. 2 is for rectum. Once again, 10 is esophagus, 5 is gastric and colon, 2 is rectum, discussion. That's how I remember it as. I can't remember descending. I only remember descending because it goes from esophagus downward. Esophagus 10, gastric 5, rectum just carcinoid 2. Minimum number of nose removed in cancer. Stomach 16, breast is 10, colon 12, and gallbladder 6. Gallbladder is small, so 6. Colon 12. Stomach is large, is 16. Breast 10. Wilkie syndrome or GI vascular compression syndrome or CAS syndrome or superior mesenteric artery syndrome, all the same. This is basically the third part of the urinary compressed by the superior mesenteric artery. Investigate CT, conservative, more important than more common to do than surgery. In case of surgery, you do urinary ingestion or stebbies or strong operation. Dysphagia lusoria, aberrant right subclavian artery compressing the esophagus. So, Wilkie syndrome, we talk about SMA compressing the third part of the uterus, whereas if you're talking about the esophagus, that's dysphagia lusoria, where aberrant right subclavian artery compresses the esophagus. Then we have blind loop syndrome, a blind segment of intestine where bacteria can overgrow. That's seen ruined by gastrogenostomy, where you leave a stump and the stump bacteria grows into the stump. And yeah. Adjustable band gastroplasty is not done anymore. They won't ask. 5 angle 45%, 45 degree. Sleeve gastrectomy. Sleeve gastrectomy, you cut the part of the stomach. 50 to 60% of BMI above 40s. Size of sleeve 32 French. Most commonly done. Reduces ghrelin levels. Run by gastric bypass. Expected weight loss is around 60% of BMI above 40. Length of run by limb 100 to 150 centimeters. Most accepted bariatric surgery. Most common side effect is Peterson hernia. Peterson hernia goes at colon coming in. Biliopancreatic diversion. Okay, this is, oh my god, I have sticky notes on this, which is way more easier to remember. So I had side-by-side comparison of each, and this is just confusing. It's just confusing. I have a side-by-side comparison using sticky notes, which is in my file right now. Check Discord. I'm afraid to. I'll check it after the stream. It's okay. Okay, BPD. So we are. So biliopancreatic diversion. So we are bypassing the pancreas and the biliopancreatic tree. Check now. Okay. I'm afraid. How bad is it? And he puts bubbles on his face. Nice. Oh yeah, the next time I go to Dubai, I have to get that. I got this really cool bubble bath soap, like the big box of it, and I really loved like just pour a little and this just the tub fills up with bubbles. I really love it, and it smells good as well. Okay, my soap is vanilla. So you're basically bypassing. Okay, simple. You're doing a gastrectomy in all of them. So in biliopancreatic division, you're cutting out the part of the stomach, and you're sending in the biliary tree to the channel. Okay, this is basically the jejunum. You're doing a jejunoduodenostomy, and from there the common channel on to the ileum. So this common channel is only 50 centimeters, where the length of alimentary limb, which is this, is 200 centimeters. Oh my god, I hate this pen. It gives me it's giving me this screeching feeling. Okay, fine now. No, my body is still vibrating. Lavender. I said I have the lavender one. Even I have a lavender one. And I also have this oil bombs. You know, those balls of oil. What is it called? I forgot what's it called. You know those balls? I used to have that. I don't have it now. It's too expensive. They're like balls that they're essential oils or something. I got it in a bathtub kit. I got it through a kit. Like 6 balls. Okay, duodenal switch. So you're doing a sleeve gastrectomy. Okay. Duodenum goes like this. Then your biliary goes separately. Be connected via the jejunum, and this is the common channel of 100 centimeters, and this is the alimentary limb, which is 150 centimeters. Side effect is severe protein energy malnutrition. SADI is single anastomosis duodenal. So there's only one single anastomosis where you do a sleeve gastrectomy. Just straight up connects to the alimentary limb. Duodenal loop, pancreatic loop. Okay, so you have a very long you have a 250 centimeter common channel. Only one anastomosis is done. I'm just buy hair removal cream at this point because one blade just doesn't want to cooperate. How much hair do you have? Okay, important triads. Carney's triad. Carney's triad is nothing but paraganglioma, cyst, and pulmonary chondroma. Meckel's triad is triad of Boerhaave syndrome, which we already discussed. Murphy's triad, pain fever, vomiting, Charcot's pain fever, jaundice. Lots triad is my mesenteric cyst triad, mild abdominal cystic swelling, mobile, particular root of mesenteric lock sign, and bowel of band resonance in front of the cyst. I think I'm gonna just try here. Okay, wait, I already read that. I just read it a lot, so it just felt like I did not read it. Welcome to having attention with this. Okay. Okay, the lock sign starts. Yes, I think we reached the end. Whipple's triad, hypoglycemic attack, sugar less than 50 mg%, and Zollinger Allison triad, gastronoma, multiple ulcers. Okay. surgery is in essence a 360-degree door. I only said 180. Oh, it's a 270. 270 is top at. 270 is top at. Door is partial 180. Watson is less than 180 degrees. Watson. And my professor put a picture here. Never stop. One day you'll be someone's hope, someone's hero. I think it does not just apply to doctors in general, and pretty much anyone. I think just anyone. One day you are gonna be someone's hope and someone's hero, so keep working hard towards whatever you're working. Maybe not as a way a doctor, maybe some way or the other, you're gonna save someone's life. Financially, medically, mentally, I don't know. Or give life. Have babies, give life. That's a way of saving the world as well. Apparently. Or save cats, I don't know. I'd consider saving cats. But this is quite a lot, but urology takes very little time. So this 30 pages is really short, doesn't take much time. However, this is a monstrosity. Just 80 pages is gonna take the entire thing. It's gonna take 4 hours. It's gonna take 4 hours because there's a lot of content in it. And I'm gonna be stuck at aneurysm for sure. There's a lot to read in this, so yeah, we're gonna keep this for tomorrow. I think we're done for the day. Thank you guys so much for joining. Thank you for surviving through this. Let's rate someone before we end the stream. Actually, I thought it's gonna take another hour to finish it, but I'm so surprised it finished so quickly. Let's see who's rating and rate them. Oh wait, Nino. So Nino is a bunny VTuber. I met her on Twitch Creator Club, and she's a really friendly person. So anyway, thank you guys so much and support her. She's also a bunny VTuber. Love you guys. See you tomorrow morning. You want me to suggest him, but I want to rate Nino because I'm never there. So next time, thank you. Guys, join in. Hop in. Everyone hop in. Let's do one person who did not hop in. Come on. So what now? Bye-bye. See you guys tomorrow morning. I think Juice would still be awake by the time I start streaming. Bye. Yeah, I'm gonna sleep.